Hello, FloodGate family. Thank you so much for tuning in and joining us for Today in Wound Care. There's a lot happening in the segment of the market. So we've invited Martha Kelso, who's the CEO of Wound Care Plus, to come talk to us about it, educate us. Tell us a little bit of her insight, as a clinician and a longtime expert in the wound care market. Martha, thank you so much for joining us.
Yeah, thanks to FloodGate Medical for highlighting this really important topic. Thanks for having me.
Absolutely. And Martha, I've had the opportunity to get to know you a bit, but I'm sure not everyone listening here has been as lucky. So tell us a little bit about you, of course, and Wound Care Plus.
Sure. Thank you so much. My background actually is in healthcare. I started when I was 15, so a little more than 3 decades in the industry. I love the post-acute care industry. I founded Wound Care Plus about 7.5, almost 8 years ago. We're now in multiple states, and we're looking to expand even further.
Yeah, excellent. So today, wound care is a big, lot to talk about in the space. We're going to narrow it down a little bit and talk about the CTP space. So again, not everyone's an inside ball game. So for those who don't know what that means, can you tell us what that is, and then kind of why it's on topic right now?
Sure, yeah. CTPs is the term that Medicare is currently using for cellular tissue-based products. So CTP, and CTPs really addresses a wide group of basically synthetic or could be allografts, human derived, or even animal derived grafts. So typically thinking synthetic, something that we're not harvesting live from the human body, different than split thickness grafts or full thickness grafts.
Got it.
Something that's manufactured, I guess, maybe is even a better way to put it.
Yeah, it isn't directly grafted right there at the site. It's brought in secondarily. Yeah.
Correct.
Yeah. So, all right, there's been a lot going on in this space. So can you give us a little history here, what's happened and why CTPs are such in the topic, and to use another acronym, the LCDs, and what's going on there. So give us a little history on that, Martha. I want to understand, bring people up to speed why this is important right now.
Yeah, so the space has grown enormously since I was running the wound center, a decade or two ago. And with that growth has come a big drain or a big cost to Medicare. And so Medicare has been looking for ways to what I would call balance the budget or help keep the budget in line. And they started giving us some rumblings a few years ago that maybe they were looking at changing the cellular tissue-based space. And back last year, they started opening it up for comments, like, here's what we're going to do. What do you think about that? Lots of groups commented, and we knew that some changes were coming. We didn't know what they were going to be in full transparency. And so a couple months ago, Medicare decided to hamper the application of skin grafts in 3 out of the 7 Medicare administrative contractor areas, or MACs. They decided to limit the number of skin graft use to 4 total applications for the lifetime of that wound, and even more so within 12 weeks from the time you start applying. So it definitely shook the industry, shook me to my core as well, because 4 applications obviously is the wrong answer to the problem of how do we balance the budget, or how do we keep things in line for Medicare dollars or spend.
Yeah, because it costs a lot more to treat amputation or patients who aren't healing, et cetera. I absolutely agree with that. I'm going to be asking some questions, but this is a meaty topic, and I'm sure some people have some direct questions. So just comment below or on the side, however your screen is, and we're going to pull those in later. So just as you think about it, just put a comment in there, and we're going to pull them in later. All right. So they limited it to 4, but then they also kind of narrowed the offering too. Correct? Wasn't that the second thing? The second choice?
And I've heard different schools of thought on that, where some people said, nope, they've absolutely limited it to diabetic foot ulcers and venous leg ulcers. And then others said, no, they're only limiting the 4 applications in 12 weeks just to DFUs and VLUs. All other wound types are fine. And so there was some people were emailing Medicare or even questioning Medicare on what their true intent was. I'm not sure that everybody landed at the true intent of that. It was still kind of up in the air, in my opinion, when Medicare backtracked.
Yeah, yeah. And they limited the type of products, right? Or which products qualified.
That is correct. They did move numerous products to an uncovered list, and yet some of them were left on the covered list, even though some on the uncovered list and some on the covered list were same or similar.
Okay. Yeah. So you mentioned it got backtracked, right? There's
Yes.
probably a couple reasons. One of the 4 applications. Give me a little bit of background on how they arrived at that, and maybe your opinion on why they might be adjusting that.
Yeah, I'm going to speak from my experience. I can't obviously speak for Medicare. I don't have the authority or permission to do that. But from my experience, I emailed Medicare, or I shouldn't say Medicare. I emailed the 3 MACs specifically that had limited 2 CTPs down to 4, and point blank asked, why did you do that? What is your reason? And I cited the 21st Century Cures Act in my letter to them. They responded by saying, if I had read the LCD changes, I would have realized that it was due to the Armstrong study. That's how they quoted it to me. And they even listed the quote Armstrong study in the bibliography. The challenge is there's numerous authors on the Armstrong study. So in a lot of, world-renowned, well-published, lots of researchers, brilliant people. I happened to be included on that study. And so I knew that the Medicare claims data study that they were citing did not suggest that we should limit to 4 graft applications, let alone in a 12-week mark. Matter of fact, 12 weeks wasn't even mentioned in the study. So in my response back to the 3 MACs, I pointed out to them that I was one of the authors, and I did question Medicare on whether or not they truly read the study. Because had they read the study, they would have realized that 4 applications was the wrong number to land at. And so if you hear, Dr. Alan Forsyth or Dr. Bill Tuttlebach discuss this, you'll hear them talk about 4 applications only is no better really than the standard of care. So you'll land at about a 30 to 35% heal rate using 4 applications. 1 standard deviation would land you at a minimum of 7 applications. Keep in mind, though, this is a Medicare claims data study from HOPD settings. The reason why that's important is because we know, because of the bundled payment methodology, we typically don't apply large skin grafts to larger wounds. It would cost an extraordinary amount of money to the hospital or to the outpatient wound center market, which means the majority of these claims data studies that we analyzed were most likely smaller wounds, which means 7 applications minimum for smaller diabetic foot ulcers. If we look at venous leg ulcers, we know that that needs even more applications. And then my neck of the woods in the post-acute care setting, we're not dealing with ambulatory people that are walking in and out of the wound center. On average, we see, 15 to 20 years of age added on top of that population, plus a lot more polypharmacy and a lot more comorbid medical conditions. Sometimes 15, 20, 30, 40 ICD-10 diagnosis codes on this chart, which means we're on average applying 10, 11, 12, 13 grafts to these smaller wounds to get them to an 80 to 85% closure rate. Wow. And so it was a little alarming to get that response from the 3 MACs that had limited to 4 graft applications using that study. Yeah.
No, hey, you should know you're one of the authors and we're deep into it, right? So the 2 main changes, the number 4 was the study that didn't align, and then some of the selection of products, there wasn't as much rigor on what was on, what was off, given the fact that some products were on both sides of the fence and it was the same product. So definitely. So it sounds like now what's happened after kind of all this come to light, this rethinking, some of the, maybe we would say kind of fallacies of thought.
Yeah.
They've reversed that today.
They did. Yeah. They put everything on pause. I wouldn't say they've reversed it or stopped it, but I would say they've put everything on pause. To be determined is kind of where we're at. I hope that what they do is convene a technical expert panel of wound specialists that are intimately involved in the CTP space. And I do want to say some people use the word CAMPS, which stands for cellular, acellular, and matrix-like products. So CAMPS is the updated terminology. I'm using the word CTPs on purpose because that's the terminology Medicare is currently using. And so when Medicare is using that terminology, that's what I want to use so that I don't confuse the issues. So I truly believe Medicare wants to do the right thing. I don't think Medicare wants to eliminate CTPs or CAMPs from this space because CTPs are what we add into a wound when the wound needs help or the body needs help healing. Dressings support the body's ability to heal. CTPs are something we put in the wound to support the physiological healing state. It allows cells to proliferate. We're getting a scaffold or some type of matrix into the wound to help cells migrate. And so in my mind, CTPs are what we use when the body can't heal itself and dressings are not supporting the body's ability to heal in and of itself. I don't think Medicare wants to eliminate it. I just think they need help choosing, helping what we would refer to as an on-ramp. Here's when it's appropriate to apply CTPs, not limit the number. I think that's the wrong thing to do. That assumes we have cookie cutter wounds and all bodies heal the same. They don't. So
we know that. And one more reminder, guys, if you have questions, just put some comments down below and we'll pull in those comments and questions here after a little bit, just to allow you guys to ask Martha what her take is in different subjects around this topic. So, so where do we sit now? What should people do now, right? As they made this, they pulled back, whether industry, whether clinicians, what would you recommend as we sit here today?
I think everybody coming together, the manufacturers, the alliances, the spokesperson, the stakeholders, but the providers too. Anybody with an NPI number that is using CTPs in their practice and has seen those positive benefits, we have to come forward as a group. Medicare doesn't want to be beat up. The MACs don't want to be beat up. I genuinely think they want to do the right things. They just don't know what those things are. Come together with a collective voice and give that guidance to Medicare or to the MACs to help them make those correct decisions. And so my guess is they're going to have more commentary periods, but ultimately I really hope they develop a technical expert panel. For providers, if you have not taken the time to raise your voice, do it now. You can send emails directly to the MACs. Every single one of them has a provider advocacy division or some email that providers can email directly to the MACs, and the senior medical directors see those emails, and it helps them decide or choose what to do next. They do care about, quality of life. They also care about ensuring wound chronicity does not go longer than it needs to be, but they also care about the fiscal responsibility that they have under their budget. So grab us, grab NPIs, grab providers. Let's get together and let's help make that voice so that Medicare or the MACs can help make adequate and appropriate decisions.
No, that's important. That's important. Come together with one advice. Here's when it's appropriate. Here's where the decisions are. Because at the end of the day, it's going to cost the MACs and Medicare a lot more to treat that patient whose wound doesn't heal and they're going to amputee and all of that down that path than it will be just simply heal correctly on a consistent basis, right? So that voice.
It's what was so interesting and somewhat befuddling because, again, the study that we spent years analyzing the Medicare claims data actually shows if you are following parameters for use, so applying early and often to the wound that's going to chronically stall, you end up saving Medicare about $10 million annually So doing the right thing for the right reasons with the right documentation and the right reimbursement saves Medicare a ton of money, not a little amount, a ton of money. And that includes amputations, hospitalizations, minor amputations, so on and so forth.
Yeah.
One more thing that you brought up earlier that I wanted to circle back around on was about the product selection. And I did ask that question in my email to the MACs. How did you choose? Because we have some products that are, say, derived from pig intestines that you left on the covered list. And then we have other products that are also derived from pig intestines that you did not leave on the covered list. Help me understand. And there was actually no response. They did not respond to that question for me. They did list a set of criteria that was, for example, from the FDA. One of the things was that it had to be a specific term from the FDA. I'm trying to think the term that they used, but it was basically like calling it a scaffolding. But the problem is that the majority of skin grafts that we're putting down in the wound are an extracellular matrix, and ECMs are scaffolds by definition. And so what the FDA has them call it versus what Medicare was wanting them to call it it's literally the same terminology. They're just using two different words. And so Medicare was using that as a reason to eliminate particular grafts, which was an incorrect reason, by the way. And so I think that's come to light now.
Yeah, that's good. I like, and you know what, I applaud them when they realize that there was inconsistency, that instead of just plowing forward, they paused it, right, to explore and acknowledge that. So I mean, that doesn't always happen in life. Many times people make a decision even when they found it's wrong, they continue.
Yes.
So I will applaud them for understanding that. I'm going to put some questions. I see we got a few here questions, but before I switch to the question, I got one last one for you. And this is the wound care market. It's been growing 6%. It's dynamic. Why is it, even with all these changes, a great time to be in wound care now? Whether it's a clinician thinking about putting more of their practice into it, or someone in industry that might want to explore this side of the medical market. Why, in your opinion, is wound care such a dynamic space to be in?
Number one, it's growing. The number of wounds in the United States are growing. I think we're somewhere around, several million wounds in the United States. And it's billions of dollars in the United States that we're spending. And aside from that, people are living sicker and sicker. And so because they're living longer and longer, yet sicker and sicker, they are going to have more wounds. And sometimes these are rare wounds, but honestly, numerous wounds have mixed etiology. I love it when there's new technologies that come to market, because all I think about is I get more tools in my toolbox. The more stuff these manufacturers bring to the market, the more stuff I have to heal people, bigger, better, faster, stronger, and sometimes less pain, sometimes less effort. And so don't stop. We want this stuff in our arsenal. Keep bringing it. Give us more.
Yeah. No, that's all. I mean, that's a great thing. I mean, unfortunately, the population is growing. Part of it's because we're aging, part of it is we're not living maybe as healthy. And so, but having those tools to be able to heal with less pain and faster, and being able to provide it, there is a ton of innovation in this space. I've seen it. And I guess as a clinician, having more tools in the toolbox makes it, more engaging to be able to give care, because you can improve the quality of life of someone that much faster.
Yeah,
right. So,
exactly.
Yeah, very cool. I'm going to switch to some questions here. We'll pull up some questions that we have here. So we've got Sean here. Are amnio patches more effective than manufactured patches?
I'm going to defer to the clinical evidence. It's interesting because there's actually quite a bit of clinical research studies out there on CTPs. And I mean, going back for decades. And so we knew that when we had to answer some of these questions to Medicare and kind of what I would say buck up to the MACs that made these changes. It wasn't like this space is not well researched. It's been well researched. And so even calling for more evidence for different patches or different skin substitutes probably isn't appropriate at this point. We've got tons of evidence out there. And so there's no such thing as a cookie cutter wound. Not all CTPs work well for all patients. We have to look at the evidence, see what works for this patient and what works well for the clinician. Ultimately, I'm a big fan of ensuring these products have coverage in various places of service or different spaces. Not all CTPs have coverage in site of care 32 or 15 or 12 or 11. And so if it's something that you really want in your toolbox or your arsenal, petition your payers and ask them to cover it in the various sites of care.
I think you had an example where you were able to do that years ago, right?
That's correct. Yeah. The very first CTP that we got covered was back in the early 2011, 2012 in post-acute care space. And I worked with Antonio Montecalvo to get it covered in the long-term care arena. It was not easy. It took us months, almost a year. But it was simply by asking and asking and asking again.
Yeah. And now you've got a tool in your toolbox for those patients who are, as you mentioned, 10 to 15 years older even than the ambulatory patients. So
that's correct.
Guys, put some questions below if you have anything else. Right now, I'm going to pull on one from Michael Dorso. Says, do you think there'll be a move to more autologous products in general?
I don't know. I don't know the answer. And I would say that, again, it really depends on the site of care that you're treating that patient or that wound. I will tell you that Wound Care Plus, we have very specific protocols when it comes to CTP use, and it's not a free-for-all. If we're allowing it to be a free-for-all, that's going to cause the MACs to retract or pull back even further. So I was involved in the platelet-rich plasma study with CMS, the CMS covered PRP study. I can tell you that I've personally seen PRP work in the wounds that we were allowed to apply it. It doesn't mean that autologous works for everybody. If they have a myeloproliferative disorder, if they're on chemotherapy or some kind of immunosuppression, autologous may not be the best choice, where, more of a synthetic type product might be. But I think developing protocols and making sure that your group is following the protocols, when to choose, why to choose, and which wound to choose for becomes important, plus medical necessity and documenting evidence for the payers.
Yeah, it's great. That's a really good point, and how to make it the right product for the right patient. So this one from Karen, the changes will impact new innovations in wound care. Do you think some of these changes are going to kind of have an impact, I guess, positive or negative? How do you think it will help?
I'm going to say yes. And I'm sure some of the changes will be positive, and I'm sure some of them will be negative.
Yeah.
I think the main thing is getting that clear line of definition. What does Medicare want and why do they want it? And then once we get that clear line, it becomes easier for manufacturers to bring more products to the market or stay within the box that Medicare wants us to stay in. But helping Medicare make those appropriate choices becomes important. Again, asking for the verbiage to say scaffolding. Well, you've never asked for that. You've always been okay with extracellular matrix, right? And so ensuring that what Medicare wants is also on the same page as what the FDA wants when they're giving you the clearance, whether that's a BLA clearance, a 510K clearance. But we've got to make sure we're using the same language so that we're not confusing everybody when it's time to bring a product to market.
Yeah, that makes sense. It's a really good point. So we're coming up on our time, but I just, want to thank everybody for joining us here today. And Martha, thank you so much for your expertise in making a complex situation very simple, even for a guy like me to understand. So that's a pretty high bar. So you did it really well. And I'm sure a lot of people help to really understand what's happening in this space now. And week after next on November 3rd, 2nd, 3rd, 4th, is SAWC. So I know Martha's doing a couple talks there. So if you guys are out at the wound care conference in Vegas, I'm sure she will be at talks and be around. So if you have additional questions, and I'll be there as well, so you can tap us on the shoulder, but she knows a lot more than I do. So you might ask her questions. So in closing, Martha, any other thing you'd like to add in closing?
No, don't be scared. Raise your voice. Let's help all get to a common end goal. Medicare wants our input also. The MACs want our input. So let's champion forward and let's go heal some wounds.
I love it. Great ending. Guys, thank you so much. I appreciate the time, and we'll see you in Vegas.
Thank you.